inflate and deflate properly. As the diaphragm fails, and the patient's ventilation needs become more demanding, both levels can be easily adjusted to compensate for this. Patients can wear the BiPAP with different attachments. I use the sip and puff, the full face mask, and the nose pillows. I think that as soon as the patient's forced vital capacity drops below 90%, the patient should be fitted with a BiPAP. Considering the degenerative nature of ALS, it can do no harm. The patient will have that much more time to get used to the claustrophobic nature of wearing the machine and the new sensations which come with artificial ventilation. This is a very big deal for the patient, especially becoming accustomed to not taking your own breaths. My brain fought me every step of the way. You can't expect it to drop everything and go with a new method of breathing when the old way has been working just fine for 40 years. I had to reteach my subconscious to accept the new procedure. I had to fight through the false sensation of air hunger it was throwing at my senses. I had to consciously tell my subconscious, relax, I'm getting the air I need, everything is cool. Of course, I had a choice, learn how to breathe with the BiPAP or die. Even faced with this morbid choice, some ALS patients still shun the BiPAP. Non-invasive ventilation can only go so far. For me, I was on it for 3 months before I noticed it was becoming increasingly difficult to get my secretions up. I have allergies, and with these come a wicked postnasal drip. The mucus would set into my windpipe and lungs, making it hard for me to breathe. Without the ability to cough and be able to clear my secretions on my own, I had to rely on the cough assist machine, chest percussion vest, and suction to clear these secretions. The problem was that these were not as effective when having to go through the mouth to clear them. On bad days we would spend up to 18 hours trying to clear my airway out sufficiently so I could breathe comfortably again. I went through constant bouts of air hunger and would have to resort to the cough assist to force much-needed air through the blockage and attempt to dislodge it. We would rotate cough assist, suction, chest percussion, suction, then start over again. I was on the verge of blacking out. This was no way to live life. I knew what the answer was. It is the one thing having ALS leads to, and every patient is faced with, the decision to get a trach. The decision to extend your life with a tracheostomy strikes fear into the heart of every single ALS patient. It is a difficult decision to make. When trusted medical professionals give you misinformation about the trach, it makes matters worse. An ethics problem exists when a neurologist tells their ALS patient their quality of life will plummet because of the trach and being dependent on a ventilator. Why is a neurologist talking to their patient about ventilation in the first place? This is not their field of expertise. You wouldn't go to McDonald's to get an oil change for your car, would you? Same premise here. What should happen is the neurologist refers their ALS patient to a pulmonologist or an informed respiratory therapist if they want to pursue a tracheostomy so that they may ask questions of the right specialist. Alas, neurologists see nothing wrong with telling their ALS patient that if they get a trach they can look forward to a life chain to a ventilator and a nursing home. We all know this is not the case, or I wouldn't be here with you. The question of getting the trach was a rhetorical one for me. Yes, I want to live as long as possible. And, really, come on, is living with a trach going to be worse than going through 18 hours of exhaustive respiratory therapy to evacuate my lungs of secretions? I informed my neurologist of my decision. The doctor didn't like it but referred me to pulmonology and the ENT department, anyway. My quality of life improved immediately. cough assist and suction work so much better when you have a big hole in your neck to work out of. What used to take 18 hours, now took only a couple of minutes, tops, to get rid of those pesky snot balls. As far as being chained to a vent, this is just not the case. I go to baseball games, concerts, football games, shopping, and Barnes & Noble. I have traveled to such exotic locations as the beach at Perdido Key, Florida, and the women's bathroom at the Floribama. The wheelchair took a wrong turn. Oopsie. I have absolutely no regrets about living with the trach. Life is such a beautiful gift. I want to experience it even if it means I must live as a quadriplegic in a wheelchair. On the other side of the spectrum lie those people who refuse to extend their life with a trach. I do not understand this. I have a lot of stuff I want to do, but slowly suffocating to death is not one of them. We need to recognize that ALS is a unique disease which affects every victim differently. Each person has their own journey with the disease. One person's symptoms might start with drop foot in the right leg, for others, ALS might start in the arms, and still for others, their symptoms might begin with trouble swallowing or slurred speech. Building upon this, ALS patients are at different points in their life. One patient might be in their 70s and have decided that they have lived a full life. Others do not want to be a burden to their families, or they don't want their families and friends to watch them suffer. I don't agree with the latter part. If trach and ventilator care is done correctly, no suffering is involved. And, yet, another group of people might simply get bored and depressed with living as an ALS patient. I mean, how many Gilligan's Island reruns can the human mind really tolerate? Another point to consider is the patient's socioeconomic background. ALS affects people regardless of class. It ignores economic boundaries. Living with a trach and being ventilator dependent requires 24/7 care. The patient must not be out of the caregiver's eyesight at all. So this pretty much rules out nursing homes unless they specialize in trach and ventilator patients. No specialized nursing home like this exists in Arkansas, at least not to my knowledge anyway. Caring for a trach and vent-dependent patient requires an adequate support system, whether it be relatives or around-the-clock healthcare. It must be in place to care for the patient. Some patients have no surviving relatives to care for them. And some people can't afford the high cost of living, both personal and medical, incurred by living with ALS. The person is left with very little choice but to balk at the possibility of being trached. The question of extending one's life with life support is a highly controversial one regardless of the disease. It is a personal decision which every individual with ALS must face and answer according to their own situation and mindset. As for me, the answer is life. Will I live one more day, a year, 5, 10, or 20 more years? Who knows? Will I ever get tired of life? Right now the answer is no. I do recognize every person has their breaking point. Will I ever reach mine? Geez, I hope not. Living effectively with a trach requires regular maintenance. First and foremost, the trach patient must become aggressive and advocate for themselves. Hospitals and doctors will not call out of the blue to check on the status of the patient, because, quite frankly, nobody outside of their support system gives a damn whether the patient lives or dies. The patient must have a pulmonologist and an ENT, ears, nose, throat doctor, and have regular scheduled checkups with them. I don't care if everything is normal with the patient. A rapport must be established with these specialists because bad things can happen at any time. The most important relationship the trached and vented patient can have is the one with their DME provider. They need to make sure it is available 24 hours a day 365 days a year. You have fallible electronic pieces of equipment that will break. A DME which is available at any time is a crucial prerequisite when selecting one. Another thing the patient must consider is the staff knowledgeable and courteous? How much experience do they have with trachs and vents? Also, I would strongly advise against entering into a hospice program of any kind. Hospice is designed to accept patients who are at the end of their life and to keep them as comfortable as possible. Yes, they will accept trached and vented patients, but they will discourage any type of aggressive or preventive measures taken by the patient. They will kick the patient out of the program if they choose to be vigorous about their care. Back to the pulmonologist. It is recommended for the patient to get a checkup at least 3 times a year. Since the patient is trached, they are more susceptible to infections and viruses of the respiratory tract. Think about it. The trach bypasses the natural bacterial filters in the nose and the mouth. The pulmonologist should take a throat culture with every visit to see what kind of goodies are growing in there, if any. If they don't, the patient should request one. The pulmonologist will also be able to give vaccines for the flu, bacterial pneumonia, and whooping cough. These illnesses could prove fatal if the ALS patient contracts these. The ENT doctor specializes in keeping the trach and trach site functional. This includes burning off any granulation tissue that might accumulate around the stoma. A little might be okay, but if the tissue grows to where it blocks the stoma or occludes the airflow, the ENT doctor will be the one to burn this off. This doctor will also change the patient's trach. This needs to be done every 6 months. Wait a minute, I think it's every 4 months. That's not right. Does 3 months sound right? Anyone? I don't think anybody knows the correct answer because there are no guidelines for adults with trachs. The conspiracy theorist inside me thinks this is because trached adults aren't supposed to live long. Could it be that insurance companies don't want to pay for adult trach care? Could it be that I've been watching too many X-Files reruns? Hey, if I'm wrong on this adult guideline thing, please let me know. Anyway, the trach needs to be changed out frequently. If it isn't, the trach will turn into a petri dish which will collect all kinds of gross fuzzy things that will increase the chance of a nasty infection the longer it stays in there. Another thing to consider is the